Thank you, Dr. Pravan. Madam Shanti Mansal, our medical director at Apollo Institute. After such an enlightening lecture by you, I think the audience must be awake now after this. It was such a wonderful lecture to hear from you. I also welcome all the delegates, all the healthcare specialists from all over the country who have come here, who are looking after the health of our industry. Why I say health of our industry? Because you are looking after not only the people who are there, but also taking their preventive and therapeutic care of all the Indian workers who are working in the companies different. And when we are at the cusp of our economic revolution that is occurring in our country, I think we are very proud that you are taking care of the health of our people who are working in our industry. So I once again welcome you to the city of Delhi from the side of Apollo Hospital. Cardiovascular disease are the leading cause of death in our country. The most common cause of death in our country are cardiovascular diseases. So this condition you can encounter anywhere. So next few minutes before talking about new frontiers in cardiovascular disease, I'd like to talk on these this cause of acute chest pain. What we call as acute chest pain is not always chest pain. That also you should remember. It is most commonly as a chest discomfort. And often it is like a pressure sensation on the chest, or may radiate to your left arm, or even go to the jaw. Or sometimes it may just be mistaken as an indigestion, and patient may continue to pop your Digene gel, or even the physician may not understand. But it's very important to diagnose this condition. Why? Because as soon as the coronary artery gets blocked, you can see from here, the myocardium starts getting necrosis. Within first 2 hours, almost half of the myocardium gets damaged in the area supplied by the artery. And within 6 hours, the total myocardium of that area supplied by that coronary artery, like if you talk about right coronary artery or left anterior descending coronary artery, the area which can get infarcted completely within 6 hours. And then whatever you do, whether you do angioplasty or any other bypass procedure or any other medication, it will be of very limited use. I won't call it useless, but of very limited use. In myocardial infarction, in acute chest pain type of discomforts, it is called that first hour is most important. It is called the golden hour, because most of the deaths due to myocardial infarction occur within the first hour. The 50% of death due to myocardial infarction occurs within first hour. And you, the physicians who are at the forefront, at the borders, like the borders of our country, like you are at the borders, we are at the tertiary care hospitals, but you are at the point of care where these patients would present. So very important to diagnose these patients and to start treatment at your center, and then refer them to at center where they can be treated immediately. Because as you can see from this graph, the myocardium starts getting damaged, and within 1 hour the portion of the heart gets damaged, and by 6 hours most of the damage has already occurred. You can see that this graph shows fraction of myocardium that is at risk, and within 6 hours most of the myocardium gets damaged, and up till 12 hours total damage occurs. So doing any procedure after 12 hours, whether you do angioplasty or any other procedure, would be of very little use. So diagnose this patient immediately and start the treatment immediately. That is what I would like to say. And diagnosing, you have to also diagnose what are the causes of acute chest pain. The most common cause of acute chest pain may be myocardial infarction, but there are other causes of acute chest pain like pulmonary embolism or dissection of aorta. Different types of chest pain and diagnostic modalities are available, because if you give thrombolytic therapy in a patient with dissection of aorta, that would be catastrophic. So early diagnosis is very essential. How to do early diagnosis? Early diagnosis can be done easily with the help of simple electrocardiogram. In 80 to 90% of patients who have had myocardial infarction, electrocardiogram is a very useful tool, and it is very easily available at every place. Wherever you are working, whether you are working at Tamil Nadu or Kerala or Andhra Pradesh, this ECG is available at the place. And mind you, as you can see here, whether this is working or not, this is working. You can see that there is simple ST segment depression here. You can see in lead 2, 3 AVF. This shows us that right coronary artery has got blocked. So this is very important to diagnose. And here you can see V5, V6 also ST segment depression is there. So the inferior and lateral part of the myocardium is getting damaged, while if the left anterior descending artery gets involved, as you can see here, there is ST segment depression in the anterior leads. Anterior, what are the anterior leads? Anterior leads are on the anterior of the chest, V1, V2, V3, V4. So just recapitulating your whatever you have learned in earlier days in MBBS and MDs. So it is very important to diagnose this, and because if you diagnose early and transfer the patient to a center where treatment can be initiated. Treatment is not always angioplasty. Also, always remember that. If within first 2 hours you are able to give them thrombolytic drug like tenecteplase, you are able to open the artery completely and save that myocardium from damage. Not only, and if any residual stenosis there, that can be treated later on. This is called pharmaco-invasive approach. But what is the first aid in these patients with acute chest pain? First aid is giving antiplatelet drugs. Whether some of your family members develop acute chest pain, give them a soluble aspirin, 1 full tablet of aspirin, 325 milligram, dissolved in water immediately, and then rush the patient to a center where ECG can be done. You can do everything in their ambulances. We at Apollo Hospital have the advanced life support ambulances which are equipped with ECG and these diagnostic modalities. And ECG can be done within the ambulance, and patient can be diagnosed easily acute myocardial infarction. We run a 24/7 emergency heart attack program at Apollo Hospital. As soon as the patient is shifted in the ambulance, the treatment is started in the ambulance, and then the patient he reaches the emergency department, and the thrombolytic therapy or angioplasty, whatever is required, can be given 24/7, day or night. Always the cardiovascular team and the emergency physicians are equipped to deal with that. If the patient is at distant places, like if the patient is at Mathura or maybe at a distant place like Agra or where the facility is not available, then patient can be started off thrombolytic therapy and then can be shifted to a center which is equipped by angioplasty procedure. And mind you, angioplasty can open the coronary artery. Over 90% success rate is there in opening of the coronary artery, while thrombolytic therapy with the fibrin-specific agent, that is like tenecteplase or retiplase, artery can be opened in about 50 to 60% of the cases. So giving a bolus dose of tenecteplase in a patient of acute myocardial infarction who has suffered is very safe. Don't be hesitant to give that tenecteplase in your clinic or in your small hospital setup wherever you are. Because by the time the patient is transported to a center equipped by angioplasty procedure, the myocardium would have got damage, and we as cardiologists or interventional cardiologists can do little to salvage the myocardium, reverse the damage which has already occurred. So this is called a pharmaco-invasive approach, and world over this has proved that this is one of the best approaches. If you cannot reach the center where angioplasty can be performed within 90 minutes of developing chest pain, this is the guidelines. Less than 90 minutes. And if you reach a hospital, the guideline says that within 10 minutes an ECG should be done, and the diagnosis of myocardial infarction should be confirmed, and treatment should be started within 10 minutes of reaching the hospital. This is why I'm telling you, because this is the condition where we can salvage lives, and once the head of a family dies, you can assess what could be the condition of that family, where a head of a family dies and the other family members suffer that their breadwinner has died. So you can, at the peripheral centers, you can salvage these patients. And as I have just shown here, that time is the most important component here. This clock says that time, every lost second or every lost minute is damaging the myocardium cells, which cannot be salvaged again. And the angioplasty procedure is not difficult. Like this patient presented to me with inferior, you can see that there is ST segment elevation in 2-3 AVF, and the right coronary artery is totally occluded. And as soon as we did right coronary artery wiring, some flow was restored, and after balloon angioplasty, total flow was restored. Immediately the chest pain settled down. As soon as we put in a wire and a balloon, immediately the chest pain settled, and then the artery got opened, and you can see the ST segment within minutes. The ST segment has settled, and the myocardium has got reversed. the myocardium which would have got damaged, the ejection fraction would have come down from 60% to 20 or 25%. Patient is having good ejection fraction of about 55% within minutes. So that is what you can do. Talking about the advances in the management of cardiovascular disease after this emergency treatment that you can do, previously the calcified arteries were difficult to treat, and we would refer them for bypass surgery or other procedures. Now we have devices where these calcified arteries can be easily treated with the help of balloon angioplasty procedure. And these new devices that we have in our hospitals are called the lithotripsy devices. You must have heard of lithotripsy for renal stones. The lithotripsy is done for renal stones. Now we have devices in the coronary arteries where we can give ultrasound in the coronary arteries and break that calcium in the coronary artery. This is a simple device and a simple catheter which is inserted through a guiding catheter into the coronary artery to break the calcium. And the balloon emits the radio frequency pulses which get reflected from this calcium, and the calcium gets disrupted, like the renal stone gets disrupted after giving ultrasound waves for renal stones. Similarly, the calcium in the coronary arteries, which is very common in patients who are diabetes, who are elderly, particularly elderly like over 70, 80 years of age, who used to have calcified arteries, but now with the help of these shock wave intravascular lithotripsy which we have, we can treat them easily by balloon angioplasty. The condition which was very difficult to treat and had a lot of complications can be easily treated with the help of intravascular lithotripsy. You can see here the calcium which was deposited all around the coronary artery. You can see the circumferential calcium can be easily disrupted after balloon angioplasty. The calcium gets fractured, and after balloon angioplasty and stent implantation, you can have a wide lumen open up, and you are preventing the patient from undergoing extensive bypass surgery which has its own hazards. The other techniques which we have been doing at GB Pant Hospital, Maulana Azad Medical College, now we have available at the Apollo hospitals are these, the treatment of coarctation of aorta, which we have one of the largest world experience, which we started in 1985 in GB Pant Hospital, and did balloon angioplasty for these patients. How do you identify this patient of coarctation of aorta? These patients are hypertensive. And while you check the pulse, when a patient comes of high blood pressure, just take time to check their femoral pulse, because their femoral pulses are weak. Whenever there is coarctation of aorta, the femoral pulses are weak, while upper limbs is hypertension. Just simple putting your hand on the femoral pulse will help you to diagnose coarctation of aorta. And this condition where one would have treated lifelong antihypertensive treatment by this simple balloon angioplasty, and later on we developed a technique of putting stents in the arteries in this coarctation of aorta, eliminating the need of lifelong antihypertensive treatment for these patients. So a young child who is born with coarctation of aorta, which is a congenital disease, can be treated for his life for hypertension by these simple techniques of balloon angioplasty, which is very safe. Another common condition in our country, which is much more common than coarctation of aorta, is aortoarteritis, which is called also, you must have heard about Takashu's arteritis, which we have the largest world experience. It causes not only you heard about congenital coarctation of aorta, this is acquired coarctation of aorta. You see the thoracic aorta is narrowed. After balloon angioplasty, you can see the widely open the aorta, and the patient was suffering from heart failure as well as hypertension. Mind you, this results are so gratifying that after balloon angioplasty, not only the hypertension improves, but the heart failure of these patients also improves. The patient who would have died of heart failure, this patient had ejection fraction of 20%, while after balloon angioplasty on follow-up, we see that patient ejection fraction is normalized to 60%. So such are the gratifying results. Another thing that I want to tell you from my experience of 4 decades, whenever a child with hypertension comes to you, always think that this patient would be having renal artery stenosis. That may be silent, and you do a renal ultrasound and Doppler examination, often you find renal artery stenosis. And if you do balloon angioplasty for these renal artery stenosis, not only the hypertension improves, but the heart failure of these patients also improves. This hypertension can recur on follow-up if the patient develops restenosis, but that is an indicator that this patient would be developing recurrence of stenosis of the renal arteries. Then we can do balloon angioplasty easily again, and after first or second balloon angioplasty, the results are very gratifying and with good long-term improvements. And we published our initial results in 1985, in the the most important heart journal, that is called Circulation. Later on, we published our largest world experience of balloon angioplasty in the American Heart Journal in 1992. And later on, we published our results of balloon angioplasty in renal arteries also in these conditions, which in American Heart Journal 1993, which was also the largest world experience of renal angioplasty in these patients with Takashudra arteritis. We published our the results of renal angioplasty in patients with these aortoarteritis, which is the commonest cause of renal artery stenosis in our country. Mind you, if you read your books, textbooks of cardiology or medicine, you would find that renal artery stenosis is caused by fibromuscular dysplasia. But remember, in our country, renal artery stenosis in young children, young adults is caused by Takashudra arteritis. This is different what you have learned from your textbooks. So just remember that these renovascular hypertension in children is commonly caused by Takashudra arteritis, which can be treated. Initially, with the help of medical management, you have to treat their disease activity, and after disease activity treated, we do balloon angioplasty for durable relief from their renal artery stenosis and renal hypertension and heart failure. Another condition, the newer development which has occurred, is in renal artery stenosis, of carotid artery stenosis. Not only the coronary artery causes angina, coronary artery causes myocardial infarction, but important problem is strokes. Stroke, what are the causes of stroke? This is the cause of stroke. This is the common carotid artery, and you see the internal carotid artery has severe stenosis. This is the commonest cause of stroke. The ischemic strokes are the commonest cause of stroke, apart from hypertensive stroke where the brain develops hemorrhage. Ischemic strokes occur from the origin of the internal carotid artery. You can see this is a very typical location for carotid artery stenosis, and balloon angioplasty technique is effective in these conditions also. You can see a wire has been passed across the stenosis, and mind you, all these procedures done under cover of the emboli protection devices, and after balloon angioplasty you can see the artery has got opened completely. You can see here the carotid artery is opened completely, and the patient, last week itself I did a patient of carotid artery angioplasty in Apollo Hospital very successfully, and within 15 minutes the carotid artery was relieved and patient could walk to his home next day. Another common problem in our country is, besides carotid artery stenosis, are other patients who have stenosis of multiple arch arteries. They can be atherosclerotic if they are in the elderly age group of 50, 55 years of age, or even 70 or 80 years of age. These patients can present to you, may present to you with syncope. The syncope is another very common presentation for these patients. Even these patients can present with epileptic attacks. The patient may be fine when he is lying on the bed, but as soon as the patient gets up, he may develop dizziness, and there may be obstruction of the arteries going to the brain, that is arch arteries. And this patient had total occlusion of all the other arch arteries. The left subclavian artery was totally occluded, left common carotid artery was totally occluded, and this patient had severe stenosis, as you can see, of innominate artery, 95%, 99% stenosis. The patient used to get syncopal episodes, came to me from Shimla. And after balloon angioplasty and stent implantation, you can see how the flow has been restored completely, and patient became free of his syncopal problem. This is another patient. We have multiple stenosis of the subclavian artery, which can be easily treated. So I am just showing you few of examples with pictures so that you can remember, not talking about the words. This patient had severe stenosis, in similar patient with severe stenosis of the innominate artery due to Takashudra arteritis. A young female developed recurrent syncopal problems and was also relieved by the balloon angioplasty. Another area where the endovascular non-surgical procedure has emerged as a mode of preferential treatment is aortic aneurysms, whether aortic aneurysms in the abdominal aorta, thoracic aorta, or in the other arteries, peripheral arteries, iliac arteries, anywhere aneurysms can now be treated without the surgical procedure. What used to be a surgical procedure used to be such an extensive procedure, opening up of the abdomen, both the groins, and putting a graft from aorta to both the leg arteries. It's a very high risk procedure, high mortality procedure. Now we just do it with a percutaneous procedure, put in a stent graft in the aorta from both sides and exclude the aneurysm from the circulation, preventing the rupture of the aneurysm. Another condition is that of the thoracic aortic aneurysm. This shows the thoracic aortic aneurysms which we did in our early experience. and now we have a large experience of this doing stent graft implantation in the thoracic aortic aneurysms, also for dissection of aorta, which results are very gratifying, and you can obviate the need of surgery in such conditions which would have ruptured and the patient would have died. You know how Pandit Jawaharlal Nehru died? Pandit Jawaharlal Nehru died of rupture of abdominal aortic aneurysm, and we didn't have that type of treatment at that time. The rupture of aneurysm can be prevented by this such endovascular bypass graft which can bypass the surgery. So now this is an era of bypassing the surgery. This is another patient of abdominal aortic aneurysms, which large abdominal, you can see the aorta has become a balloon, and after putting in a stent graft, you can see the aneurysm totally excluded, and the graft has replaced the normal circulation is there, and the patient is now, this patient was from Jaipur and completely healthy living for over now 1 decade more. Follow-up of this patient is there. So another area that we are doing at Apollo hospitals across the country is the transcatheter aortic valve replacement, and we have done several procedures even in the Indraprastha Apollo hospitals of transcatheter aortic valve replacements. Now those patients who are elderly patients, high-risk patients, over 70 years of age, but they are having comorbid conditions like COPDs, or they are very high risk for putting in a surgical aortic valve. These can be treated with the help of some such similar procedures. Now the valves can be put into the aorta by these endovascular procedures, and their stenosis can be completely relieved. The patient would otherwise have died from this heart failure or syncopal problems in these patients. Non-surgical procedure is now available for replacement of aortic valve, which we called as transcatheter aortic valve replacement therapy, is available at our hospital also and at several other hospitals also. And this is the gradient which was severe gradient of severe aortic stenosis, completely relieved after balloon angioplasty and transcatheter aortic valve placement across in the aortic valve. So there are several procedures which are now being developed for treatment of these patients. This is another type of aortic graft that was a balloon expandable graft. Now we have a self-expandable valves to be put into the aortic for aortic stenosis. This is another new technique which is now available at our hospital as well as some of other hospitals also, is in severe aortic regurgitation, particularly secondary MR, which cannot be operated. Patient is having very severe left ventricular dysfunction, ejection fraction of 30-35%, which could not be operated. Now this is a new technique of putting in a clip, just like a paper clip that you put on your paper. Similarly, we have clips for the mitral valve. You can put in a clips with the help of this transcatheter procedure. We go from the right side, drew a transseptal puncture, go across the mitral valve and put in a clips into the mitral valve, and the severe aortic regurgitation reduced to mild aortic regurgitation, and the patient can live happily from his or her congestive heart failure symptoms relieved. Another technique which we had pioneered in this country is leadless implantation of leadless pacemaker, which first we did at Apollo GB Pant Hospital. This was one of my initial cases where we implanted a transcatheter, these pacemakers inside the right ventricle. Patient who cannot be put in a pacemaker through the approach where we put in leads into the ventricle and then start pacing. This is one of our first patients, and these our results were published in New England Journal of Medicine of transcatheter intracardiac pacing systems, leadless pacing system. It's called MICRA system. These are very small pacemaker system which we put inside the right ventricle, and there with the help of anchors, these anchors are placed into the tip of the right ventricle, and you can see the pacemaker implanted, and on follow-up also these the pacing can be done. These are very helpful in patients who cannot be done the pacemaker procedure through the percutaneous approach, or those patients who have undergone pacemakers but have developed recurrent infections or any allergic conditions, or those who have comorbid conditions and cannot undergo the pacemaker implantation. So these techniques of leadless pacemaker systems are very effective, and we have been doing routinely these pacing systems. So dear friends, from all over the country, now with the help of these newer techniques that are available to the patients prefer to these endovascular procedures for number of disease conditions, and they do not want themselves to get operated, and preferentially they want to get treated by the help of endovascular approaches, which can be done percutaneously. Even the large transcatheter aortic valve can be put percutaneously. Previously used to require surgical of arteriotomy, but now we are having systems where these arteries can be closed with the help of percutaneous procedures, and all these procedures can be done percutaneously, giving them a healthy life, long life. Thank you very much for your patient listening.